So we're going to get started now. Thank you, Ajay, for joining us. As I explained, we have a hybrid in-person and Zoom, and so we have people filtering into the conference room, and we have, people logged on. I really want to, thank you for taking the time to do this. Ajay obviously needs no introduction. He's, a very good friend and mentor to me since I was a fellow at Columbia. He's professor of medicine at Columbia, and he's also director of the cath lab there. And a lot of us also know him from, his work in clinical trials and with CRF and education and, the different courses and conferences. And, I think Ajay has a very correct reputation as sort of a thinking interventional cardiologist, and something, I've certainly tried to take from him and apply to my own practice. And he's going to speak to us today about the role for coronary revascularization in stable ischemic heart disease, which is something that I think is getting, challenged and discussed a lot more over the last few years. And he'll, give us an overview really of what, our contemporary approach should be in 2023.
Thanks so much for having me. Sorry I couldn't be there in person. We're just down here at the CRF Fellows course, and that's why I also thank you for starting a little bit earlier so we could get to the sessions. Also, the introduction was great. The only disadvantage I have compared to Yusuf is that my accent doesn't make me sound like a thinking interventional cardiologist, whereas he already starts up, two feet ahead of all the rest of us. So we always used to, give him props for that. So I'll speak from mainly a clinical perspective, talk a little bit about data, show a couple of cases that I've dealt with. These are all my conflicts. I list absolutely everything on here, but it's research grants to Columbia and CRF for the trials that we do, as well as the educational work that we do. I'll start with a representative case because I think, Yusuf, you said it right by saying, what we've been doing has been questioned over the past several years or so. And this was a patient that was referred to us that you may have even been around when we treated her. But she basically had a known ischemic cardiomyopathy with an EF of 30% and a CTO of the right coronary artery. Was having worsening dyspnea. Meds were escalated appropriately. And then ultimately, she was referred to our heart failure team for enrollment in a stem cell trial or advanced heart failure therapies at that time. And I got a call from one of my heart failure colleagues who said, I think she needs a cath. But interestingly, all this workup that had been going on at the referral hospital did not include recathing the patient. And we'll come back to her at the very end. I think that it can be safely said that this paradigm of less is more, which is actually promulgated by, prominent journal, JAMA Internal Medicine. They had a whole series titled Less is More, can be summarized in this picture, which was, a little bit dated, but I think it's still the way a lot of this is taught. And it's basically that in stable ischemic heart disease, if you're empowered as the patient, the healthcare system is predatory upon you. We just want to make money. We want to do procedures. And saying no is the word that actually can save your life because there's implication of harm. And by the way, the healthcare budget's spiraling out of control. So this could also solve that problem as well. Now, how did we get there? Well, I think we got there because appropriately, when people looked at rates of PCI that were occurring in the United States, and we'll use PCI as an example, but you could look at surgical revascularization as well, but it was more pronounced with PCI. There was a lot of disparity. If you adjust for age and comorbidities, you see there's certain hotspots that do a lot of procedures, and there's certain cold zones that don't do as many. And that really shouldn't happen if patients are presenting the same way. Of course, there's some mild practice variability as well. And so this led a variety of societies to come forward with the appropriate use criteria for coronary revascularization. About 10 years ago, this was kind of like a bad word among, not only interventionalists, but also nuclear cardiologists, echocardiographers, et cetera. But it actually was a good intent. And the idea is to address these disparities in care and try to figure out a way that we can regularize it and come up with scenarios for which it made sense to revascularize patients. And when these were published, actually, interestingly, we saw that over time, right after they were published, the rate of appropriately rated PCIs at the patient level and the hospitalization went up, and the rate of inappropriately rated PCIs went down. And this was not just all coding. This also happened in a backdrop of trials like the COURAGE trial being presented and published, where I think the days of treating a OM3 lesion and going and telling the patient you saved their life, which is actually I saw some of that during my training. That's kind of gone away now. I think most of our trainees don't actually say that to their patients when they treat, a distal branch lesion in a relatively asymptomatic patient. Hopefully they're not treating those patients. But what's interesting is that if you look at the earliest iterations of these types of criteria, the appropriate use criteria, they actually started in the 1990s in LA County. And it wasn't to identify overuse of procedures. It was actually to identify underuse. The idea here was that there may be patients in LA County in this study who had criteria for coronary revascularization. In other words, they had symptoms, they had a bad anatomy, and yet they weren't getting revascularized. And it turns out in that study published in JAMA in 1995, those patients that didn't receive revascularization had the highest rate of mortality, and those that did actually had lower rates. And so the idea here was to identify those people who were not being offered appropriate revascularization and then somehow find a way to get them treated safely. This issue of undertreatment is real. I'm not saying that there's no overtreatment. There can actually be at the same time overtreatment of simple cases and undertreatment of complex cases. And this is just another example of this, where in the Action Get With the Guidelines registry, patients came into the hospital with non-STEMI and known left main 3-vessel disease. So 2 class 1 indications for coronary revascularization. And yet there are hospitals here on the right of the slide that are treating 30% of patients who present this way medically. Now, it's possible that some of these hospitals are close to, assisted living facilities, and the average age of these patients is 95 and they're comorbid, but that's not the distribution of all the hospitals here. And so there clearly are people who are not being treated that have high risk features. And we looked at this, and Darshan Doshi, who's now at the Mass General, was one of our fellows, who was actually original complex high risk fellow, looked at this in a large database. And the way we looked at it is we looked at patients who had the diagnosis of heart failure at the index hospitalization. And we looked not how often they got revascularized. We just looked how often they had a test to assess the etiology of their heart failure. In other words, was it ischemic or not? And it turns out that within 90 days, only 30% of patients had a stress test or something to look for ischemic heart disease as an etiology of their new heart failure. Now, some people actually said after we published this that, well, this is clearly underreported and that sort of thing. And I actually think in an insurance database where you're looking at procedures, it's less likely to be underreported, but double these numbers, make them 60%. It still means that 40% of patients with new heart failure as a principal diagnosis are not getting tested to determine why they have heart failure in the first place. And by the way, it's not just about coronary revascularization, and you're going to hear that theme throughout this talk. It's also that guideline-directed medical therapy, once you make a diagnosis of ischemic heart disease, tends to be more appropriate. And this is nicely shown in this study here, where in patients that had angiography, there's greater use of aspirins, statins, beta blockers, and ACE inhibitors compared to those that don't have angiography. In other words, of course, this can be confounded, but the bottom line is that if you don't know what you're treating, how can you treat it effectively? And that's, I think, to me, the most compelling argument to make a diagnosis. And I know that Eric Velasquez and I have talked about this, and we recently were in a symposium together where we both converged upon this point. So, but why should we revisit the role of revascularization? I think the reason is what we really want to do is we do want to think. We don't just want to treat everybody the same way. And so we want to take the right patient for the right reasons, revascularize them if indicated in an ischemia-driven fashion. And if we do that, then we can optimize outcomes both for the patient as well as cost for the system. So it's not take everybody, it's try to figure out who we should take. And so that's what this talk is about. So 2 goals of therapy in patients with stable ischemic heart disease. First, we'll talk about symptoms and quality of life. This is actually fun. I think it's funny. It's measured by what's called, in some ways, I think it's a pejorative, soft endpoints. But for many patients, these are the things that actually affect them more than, whether you're going to prevent a high sensitivity troponin elevation in the follow-up period. Also, we'll talk about improving prognosis, but let's first start with symptoms. It's pretty clear that prior studies have shown demonstrably that PCI and surgical revascularization can reduce patients' angina. In fact, many of the prior studies when I was a fellow suggested that we would reduce angina, but we would potentially expose the patient to increased harm. And that's why we have an informed consent discussion with our patients. This was somewhat called into question when the Orbito trial came out just about 5 years ago. And what Orbito was, it was a randomized trial with a sham control group. Much has been made of the sham control group, and I do want to commend the investigators for doing the sham control. But what's interesting is that the primary endpoint of exercise time was actually increased in the PCI arm. It just wasn't increased to the level that met statistical significance in the trial compared to the sham arm. If this study was twice as big, it would have been significant. But it's not a matter of significance, it's a matter of how much the exercise time changed. And I think what was important from Orbita was that the actual incremental difference between PCI and the sham group was not as much as many people might have expected. And the reason for this was that most patients were actually well controlled with 3 or more antianginals. And so if you take somebody that doesn't have a lot of symptoms and you revascularize them, you're less likely to get a symptom benefit or a change in their exercise time than if they had more symptoms, for example. Now, what's interesting is the Orbita investigators, and this is less well known, published a follow-on study in Circulation, and I was actually able to write the editorial for this. And what they showed is that when looking at this in a more conventional way, not just exercise time, but just angina, do you have angina after the procedure, there actually was a difference in favor of the PCI group compared to the sham group within the trial. And while much has been made of the sham group, if you compare Orbita here on the right to these 2 other trials, VA, ACME, and Courage on the left, actually the difference between the 2 arms is very, very similar. So there's not a sham effect per se. It's really that it really depends on which patients you're taking and which patients you're successfully revascularizing. I will say, though, as a general rule in clinical medicine, we don't practice with sham groups. And so if you feel that you're revascularizing a patient for the right reason, in other words, they have significant symptoms, they have a 90% LAD, I wouldn't go to that patient afterwards and say, well, you know, the randomized trial data is not really certain or conclusive whether you're going to have a difference between sham and what we just did. So let's see how you are in a few weeks. I think as a clinician, you should be honest and upfront about the patient, about the expectations, and say, listen, we treated you for this reason. We feel like you're going to feel better. Please let us know how you're doing and do the procedure in the right way. So that's, I think, a good learning point from the trial. One of the interesting things that's happened since Orbita and even before then is this algorithm for the way we treat patients' symptoms for stable ischemic heart disease. And the algorithm, which is in the guidelines, is basically take patients, treat them with sublingual nitro, then try a beta blocker, consider calcium channel blocker, add ranolazine, and only after all of that is done ought you to consider revascularization to improve symptoms. So in other words, potentially 3 or 4 classes of anti-anginal therapy before you go to revascularization. The question I have is, if you're very symptomatic, do you really want to go this route? And the reason I question it is because if one looks at hard outcomes, in other words, do any of those agents prevent adverse cardiovascular outcomes in patients with stable ischemic heart disease? The answer, especially if your ejection fraction is preserved, is a hard no. So beta blockers, no benefit. Nitrates, no benefit. Calcium channel blockers, ranolazine, no benefit. And some of these have side effects. In fact, I would argue that the agents that are not on that former slide and algorithm that actually have the most benefit, aspirin, statins, and lifestyle modification, should be really emphasized. And these agents for anti-anginal purposes, really it's a patient-oriented decision based upon how severe their symptoms are. Now, the question is how good can we get with PCI? And what I want to commend the Orbita investigators for doing is they did a follow-on study where they actually took patients in the cath lab with physiologically significant lesions, opened their artery, single vessel disease, very similar to the Orbita population, and then told the patients, your artery is open, exercise as much as you can. And interestingly, in that setting, they actually got an increment in exercise time that was far greater than seen in Orbita. And the one reason for that, at least in Orbita maybe, is that if the patient didn't know what procedure they got, it's possible they actually held back on the initial stress test, whereas in these cases, they had a much greater incremental change in their exercise time. The other aspect of this that was super interesting to me, at least, that was published in JACC, was that while in the beginning, these patients had angina and all stopped due to chest pain, once the stenosis was relieved by PCI, none of them stopped due to chest pain. They all stopped due to physical exhaustion, and that was associated with an increase in their lactate. So basically, if they're having symptoms and the lesion is physiologically significant, their symptoms go away and they stop due to physical exhaustion. Now, this is a highly controlled experiment, and in clinical practice, it is often very difficult, especially I want the trainees to understand this, to truly ascertain what the patient's symptoms are. If they have typical chest pain, it's one thing, but if they have exertional dyspnea, I've seen a lot of people say, to a COPD or, oh yeah, if I relieve that stenosis in your distal right coronary artery, your shortness of breath is going to get better. That doesn't work that way. You have to be a good clinician and understand what else is going on with these patients. In addition, if we sort of take the paradigm of let's take the most symptomatic patients and treat them with coronary revascularization, you'll see what you found in the COURAGE trial. COURAGE was a randomized trial of PCI plus medical therapy versus medical therapy alone. And in the trial, if you didn't have a lot of angina at baseline, the medical therapy arm didn't need to cross over and have a PCI because the trial was a strategy trial. It allowed patients who failed medical therapy to cross over and have PCI. On the other hand, those that had daily angina or more frequent angina had a much higher rate of crossover. And this makes perfect clinical sense. If I have somebody come to my office, they have chest pain about once a month, which is, by the way, how it was in Orbita, I'm totally fine starting them on medical therapy as long as I make sure they don't have left main disease or something like that, because those patients are generally going to be controlled with the medicines I give them. If somebody's having angina every hour, you got to admit that patient because that patient's either unstable or has a super tight stenosis causing their symptoms. So these are basic clinical facts that I think all of us know, but get lost in the data where we try to amalgamate the treatment effects across all patients who are randomized. The final point I'll make is about de-escalation of medicines and the fact that if you revascularize, you can get this increase or this improvement in symptoms with less anti-anginal agents. So there's less nitrates, less calcium channel blockers in the COURAGE trial. The ischemia trial showed the same thing as well, and I'll show you that in just a second. Another attribute of these trials that's important to understand a little bit about is how angina gets measured. And so John Spurdish came up with the Seattle Angina Frequency Scale, and I think he was a resident when he did it. Very simple question. Over the past 4 weeks, how often have you had angina? These are sort of the cut points, and they tie onto the score. So 100 means no angina at all. 20 means you're having angina 1 to 3 times a day. This is kind of a rubric that he's come up with: daily, weekly, monthly, or none. And so the question is can you find this effect where if you have more frequent angina, that's the patients who are going to have the biggest benefit? So we'll look to the ischemia trial for that. And remember, the ischemia trial published a few years ago randomized patients to an invasive strategy, i.e. cath, versus medical therapy alone in patients that had higher risk stress tests. And so the whole randomization was cath versus no cath. Because it was cath versus no cath, you couldn't take people in the trial who had daily angina because there's no way you could randomize them to no cath. So in general, the mean SAQ in ischemia was 80, which meant monthly angina. And within the ischemia trial, you see the exact phenomenon that I'm talking about. And that is that if you look at the difference in the treatment effect in the two arms, blue being conservative, red being invasive, if you have no angina at baseline, there's really no difference in the arms because you don't have to cross over. You don't have to have a cath because you don't really have a lot of symptoms. On the other hand, as symptoms become more and more progressive, weekly to daily, the number needed to treat to render a patient angina-free becomes 3. And by the way, this effect is durable to 12 months and 36 months. So take the patients that have the most severe symptoms. Those are the ones who need the cath and need potential revascularization to help their symptoms. And then, by the way, you can wean them off their medicines because they're going to be less anti-anginal use if you do that. Or if you have people that are less symptomatic, why not try medical therapy? And they may not actually even need any medical therapy in terms of anti-anginals that don't affect their prognosis. Just double down on their statin, aspirin, lifestyle prevention, and the like. The final point I'll make about symptoms is that we have to be better doctors. This was from Mid-America Heart Institute, and they looked at anginal frequency when they assessed their patients. They also asked the physicians taking care of those patients, is your patient having angina? And their patients that were physicians that were really good, they were totally concordant with their patients. Physicians over here that underreported their patients' angina, the patients that I have angina on the SAQ, and they asked the doc, and the doc said they're not having angina 80% of the time. So what we have to do is take the time to actually talk to our patients. So when I see somebody in the office, one of the reasons I went into a subspecialty was because it used to drive me nuts in internal medicine clinic that in 15 minutes I had to cover everything from the colonoscopy to the vaccinations to the chest pain to the diabetes, everything all at once. Whereas in what we do, we can actually cover the pertinent issues and still have time to actually go deeper and talk to the patient. And so I don't just ask them if they're having chest discomfort. I ask them, what do they do in their daily life? If they sit on the couch all the time, I know that I'm going to have a harder time, eliciting whether they're having angina. If they're super active and they do everything they want to do, well, then I have a higher specificity for being able to diagnose their angina or not. And so that actually changes how I do testing in my patients, because I can get a better pretest probability of how significant their coronary artery disease might be simply by doing the history when assessing them. And if we focus our attention on those with the most severe disease, this is data from Freedom, very similar data from Excel, similar data from Stitch, even similar data from Revive, you can see the most dramatic improvements in terms of anginal classification with coronary revascularization. So more severe disease, better results in terms of that. These are other data from patients who were surgically turned down. So they met criteria for severe disease, but they were too high risk for surgery, and doing PCI in these patients was associated with improvements in health status across all outcomes measured. So this is just an example of a case of this. And this is a gentleman who had a anastomotic lesion of his rema to his right coronary artery. You can appreciate how severely stenotic that is, kind of a weird lesion, to be honest. And this is what the native coronary looked like. So this had actually been treated with a stent before, and then the patient had recurrence of angina. Patient had been escalated on multiple medical agents, and the reason it was not considered for revascularization is because this lesion was thought to be unamenable or not amenable to coronary revascularization. So if you have the specialized training to be able to do this with a dual injection, you can see where the coronary is. You have an anchoring point for your guide, and that's exactly what we did. Anchored in the conus branch, actually had to re-enter with a Stingray device, re-entered, revascularized the patient, and then I still see him, I think 6, 7 years later, and immediately after we saw him for follow-up, we de-escalated his anti-anginals because he didn't need them anymore because of the fact that he was revascularized. He's remained asymptomatic and doing very, very well in that regard. And so my sort of summary point on this in terms of symptoms is, if they have real symptoms and they have real disease, and the symptoms are frequent enough to elicit consideration of revascularization, this is how they feel after you revascularize them. I thank you for all your help. It's a great feeling to be angina-free. This is much better than a tweet or a social message or a text or something like that. Getting something in writing like this always makes us feel a lot better. And certainly for the patient, we feel great. But the other question, and by the way, he's on less medicine too, because he's down titrated. But the other issue is, do we need to revascularize everybody? And I think the guidelines do get it right in saying that if they have refractory angina despite medical therapy and with significant diseases that are amenable to revascularization, revascularization is recommended as a type 1A indication. But we don't need to revascularize everybody. And this is another note from a patient who was referred to me with a CTO, and he was largely asymptomatic, but like many patients who are told they have CTOs, he was definitely afraid of this 100% blockage in his coronary artery and that he was going to die as a result of it. We had a nice conversation with him, his family. I explained the pathophysiology. I explained the risks and benefits and all of that. And we both agreed that because he felt well, that it could be treated medically. And he sent me a very nice note saying, thank you for taking the time to explain this to me. Sometimes it's actually harder to explain to the patient that they don't need a procedure than to just do it. But the reality is, if they don't need it, we shouldn't just do it. And so that's sort of my take home from the symptoms part. What about prognosis? This is a nice segue, because I think that there's been this feeling out there, and certainly if you ask medical students, if you have stable ischemic heart disease, is there any prognostic benefit to coronary revascularization? The answer is summarily is going to be no. No, this is all about symptoms and there's no prognostic benefit. Well, I'm going to challenge that a little bit and show you data that challenges it. So before I do so, I want to make sure that we get certain things right. And we talked about before about aspirin, statin, lifestyle modification. Remember, if you have stable ischemic heart disease or any atherosclerotic cardiovascular disease, all of these other things, diet, smoking cessation, blood pressure control, diabetes control, are super important, irrespective of whether you revascularize somebody or not. Specialist means I intervene in the cath lab. But that's actually not my point. I mean, when I went into interventional cardiology, I liked interventional cardiology because we could intervene. And that means I like all kinds of interventions. So some of my best success stories are folks that went to gastric bypass surgery and their diabetes resolved, their hyperlipidemia resolved, and they actually stopped having events, cardiovascular events, as a result of them. So for me, that's super important, and we really have to emphasize that better. We know from the COURAGE trial that if you achieve risk factor modification, the number of goals that you actually achieve success in is directly proportional to your survival. So this is super important. And we have a viewpoint coming out in JAMA Cardiology in the next month or so that talks about screening with lipid panels as part of the routine pre-cath assessment. I don't know if you do this, but the general recommended standard is to get, a CBC, coags, platelets, and a BMP to look at their creatinine before patients come into the cath lab. But for me, the patients coming in for a coronary angiogram where we're going to diagnose them definitively or not with plaque, why aren't we checking their lipids at that time? And why are we not looking at their lipid panel at the time they come into the cath lab? And so we've actually done that as a standard of care in our cath lab. We get lipid panels as routine pre-cath labs, unless they have a more recent one. And then at the time of the angiogram or the PCI, we can actually make definitive changes, not just say, oh, they're already on high dose statin, so that's fine. We actually up titrate based upon LDL goals. And so the reason for that is that you look at general rates of control, and we're terrible at it. In general, these are people with established ASCVD. Things like smoking cessation through legislation is much better. Glucose control has gotten better, but physical activity, BMI control, and lipid management is actually pretty bad. And so we really, really have to do much better at this. There's actually a recent publication that just came out in JACC last year, looking at what proportion of patients with CVD are on a high intensity statin. Soberingly, it's about a fifth of patients, and half of them are on no statin at all. This is a huge, huge treatment gap. And frankly, from a population health standpoint, we would make a lot more benefit in terms of patients by working on this in addition to what we do in the cath lab. So can we affect prognosis in the cath lab or in the OR? And so this COURAGE trial studied this. It came out about almost now 20 years ago and showed that there was no difference in outcomes of death or myocardial infarction with PCI plus medical therapy versus medical therapy alone. And so this is where that board review question for the medical students in a sense comes from. There's no prognostic benefit to coronary revascularization. But the reality is that's a mean treatment effect. And there are many patients, if you do a trial, who are going to have a good outcome with revascularization. There are people who are going to have a bad outcome, and then there are people who have an intermediate outcome. And when you do a clinical trial and show a single Kaplan-Meier curve, you're amalgamating all those treatment effects across all those patients to get a mean treatment difference. So on average, that's what you see. But the reality as a clinical person is that you want to actually risk stratify your patients and try to figure out, are there patients who have the highest risk features, such as high risk anatomy, who could benefit from coronary revascularization? And are there signals in those populations that revascularization might make sense? And so I'll show you some of that. I just want to emphasize this slide and mention that diagnosing and treating severe coronary artery disease is prognostically important. You can't take data like the COURAGE trial and say, well, then therefore we don't even need to do the cath to diagnose anybody, because that doesn't really matter. And that's certainly not the case. And even the ischemia trial, which I'll show you in a little bit, show that that's not the case. So why do I say that? Well, this just came out from the Annals of Internal Medicine. These are subclinical atherosclerotic disease in people who had research CTAs. So it's a cohort of patients that had just had research CTAs for asymptomatic disease. And because much of this comes to, if this is only about symptoms, well, it turns out if you're asymptomatic and you have obstructive or extensive disease, your probability of having an MI or even death or MI is higher than if you don't. So diagnosing this makes sense, even if the only thing you're going to do by diagnosing it is to escalate the statin to a lower LDL goal. So subclinical disease is important. This is from our guidelines a couple iterations ago that show that based upon your anatomic extent of disease, starting from one vessel, single vessel disease, down to 3 vessel with significant prox-LAD, the rate of survival really goes down. So if you're a 55-year-old woman and you have 3 vessel disease with a greater than 95% prox-LAD, assuming medical treatment only, you have a 4 in 10 chance of not making it till you're 60. That's prognostically important, and that suggests that you need to make a diagnosis to sort out what's happening. Now, interestingly, if you look at the US guidelines or prior iterations, and this is before the CTA-based guidelines came out, there was this paradigm, and this really came largely from COURAGE, that you did everything in terms of testing up front, short of coming to the cath lab. And only if you had a very high risk stress test would you ever go to the cath lab to consider revascularization. Why was that paradigm that way if we know that diagnosing severe disease is important? And the reality is if we look long and hard at ourselves, it's because we were really cathing too many people and we were cathing the wrong people. If we compare, this is, I think, a super important study, and I know Yusuf can relate to this. This is Canada versus the US, but certainly if you look at the UK versus the US or Europe versus the US, I just want to highlight the bottom of the slide. This is the rate of diagnosed left main or three vessel disease on catheterization in Ontario, 13%, New York State, 7%. So why is there such a discrepancy between the diagnosis of severe disease? It's because if you take an executive who comes to your office and gets a physical exam and does a stress test and has diaphragmatic attenuation on their stress test, and then you cath that patient, you're going to get a much less severe disease proportion than if you only take people that have more severe symptoms or have harder clinical indications to come to the cath lab. And in the US, we just cath way too many people, or had been. And so the reality here is that hopefully CT can help alleviate some of this, but that's why our guidelines are written the way they are, because you want to prevent people coming into the cath lab because they may end up there for no good reason, and then they may get a stent for no good reason. So therefore, you put in a high bar for them to get there. I think we should change that paradigm and basically use good clinical judgment to take the right people to the lab. And I do have some hope that CT can help in that regard, as long as we don't overreact to the CT, which, by the way, we're seeing a lot of now as well. So there are actually there are actually randomized trials looking at revascularization for high-risk anatomy. These are two randomized trials done in the 1990s looking at mortality benefit for left main revascularization with surgery versus medical therapy alone. There's some people who've said, well, these trials are dated and they're not relevant anymore. In general, I would say if you have randomized evidence of a mortality benefit like this, the onus is on you to prove that left main disease can be left alone, rather than sort of rolling the dice with a patient that has a severe left main, for instance. If it's less severe, 50% or so, or that kind of thing, that may be an area ripe for study at this point. There are also former studies of multivessel disease, similarly, high-risk anatomy, CABG versus medical therapy showing a survival benefit. But again, many people have said these trials are old, and so we need a more updated trial. And so the ischemia trial was that to a lot of people. And so it's worth talking a little bit about what ischemia was. It randomized 5179 patients, and again, I mentioned, to an invasive strategy, cath, versus a conservative strategy, just medical therapy alone. These patients needed to have ischemia on stress testing, either nuclear or even just treadmill stress testing. And importantly, they had a CTA at baseline to rule out left main disease, so that we were not randomizing left main disease to medical therapy alone, because that was thought to be not ethical. The median follow-up was about 3.3 years, so really not that long, to be perfectly honest with you. And originally the trial was designed to be a lot more patients, but they couldn't enroll fast enough. Notably, 8% of patients on the initial CT angiogram were not eligible for randomization because they had left main disease. I really think this is an important point to emphasize. This means that if you have a high-risk stress test on a patient, in my opinion, you need to get a CTA to rule out left main disease, because if that happens up to 10% of the time, because it actually is probably greater than 8%, because those patients with low GFR didn't actually get the CTA. If it's 10% of the time, that's too often to miss, given how prevalent coronary disease is. So getting that test to make sure they don't have left main disease, and then if you want to apply this approach, is probably a reasonable strategy, and that's one that I employ. Now, in the trial itself, most patients that were randomized to the invasive arm did get cath, but only 80% of them got revascularized. And it was about 3/4 PCI and 1/4 CABG. So 20% of patients in the invasive arm didn't even get revascularized. And so it's hard to imagine that you get a treatment effect of that, of revascularization seen in the trial. This is the biggest argument that the surgeons have about using the ischemia trial to inform the guidelines, is that how can you use these data if 20% didn't get revascularized? I still think it's relevant to use these data, but just have to have that caveat. Also note that about 1/4 of patients randomized to the conservative arm ultimately crossed over and had revascularization. So that also washes out a potential treatment effect. But as a strategy trial, it's a reasonable approach. Here's the primary outcome that really showed no difference over the follow-up period between the two study groups. But one thing that's worth pointing out, and Judy Hockman actually pointed out herself during the presentation, was that there seems to be an upfront harm to the cath arm, the invasive arm, and then the curves cross, and out at 4 years, there's actually seems to be maybe a potential benefit. In fact, the confidence intervals look this way. Now, if you actually take the ischemia trial results and look at the major secondary endpoint, cardiovascular death or MI, and this was, by the way, the hypothesis of the trial. It was designed to study cardiovascular death or MI. It just didn't enroll enough patients to study it. One actually sees something pretty interesting, and that is there is this upfront harm to the invasive strategy. But at 4 years, there's a statistically significant improvement in cardiovascular death or MI in the ischemia trial with the invasive arm. So I'm going to repeat that statement because I don't think many people know this, that at 4 years in the trial, there's a statistically significant reduction in cardiovascular death or MI by being randomized to the cath arm of this trial, despite the upfront risk and harm of it. This is something that has not been promulgated and doesn't really get out there. And so if you actually look at the distribution, this is a Bayesian analysis of what happens for CV death or MI. Early on at 1 year, it actually favors the conservative group because the invasive arm is going to have more paraprocedural events. At 3 years, it's kind of a wash, somewhat favoring invasive. And at 5 years, this is the probability distribution in favor of the invasive approach. So this is pretty remarkable, actually, and this actually did make it into our guidelines, which I'll show you in a second. So where did this come from? This came from the fact that they observed a reduction in type 1 MI, so spontaneous MI, if you were randomized to the invasive arm of the trial. What's interesting, and some people said, I don't understand this because these are actually people treated with PCI, CABG, and medical therapy. Why do the medical therapy people have such a low rate of spontaneous MI after they come in and get cath? And the reason is because when we cath somebody, we triage them. So if you're triaged to medical therapy, you're likely low risk. If you're revascularized with PCI or CABG, your risk has been reduced. And therefore, all those groups are better than the conservative arm, which, by the way, includes some people who didn't need to be revascularized. So the revascularization effect is even greater than was obscene in this trial. Now, this obviously has to be weighed against the upfront risk of doing a procedure, revascularizing patients as well. But there's actually a lot of data out there that shows that revascularization can improve spontaneous MI. This is a meta-analysis published in 2013 of PCI versus medical therapy trials showing a reduction in spontaneous MI. And then the FAME2 trial, which was published in the New England Journal in 2018, showed exactly the same thing. So this theory that we cannot reduce heart events is actually not only disproven by further data, but the ischemia trial itself further disproves that belief. And finally, the ischemia extend analysis was published last year. And in that analysis, there's a reduction in cardiovascular death with follow-up out to 5.7 years with the invasive arm of the trial. Now, the caveat of this is, number one, this was predominantly observed in multivessel disease patients, so that makes intuitive sense. But it's also offset by an increase in non-cardiovascular mortality. And people don't really understand why that's the case. I certainly can come up with some hypotheses, but don't know for certain. But this actually allows one to sort of be circumspect about it because you're not going to overall save lives. You may reduce cardiovascular events in patients by revascularizing more severe disease, but we're not going to reduce overall mortality, at least to date. And the ischemia follow-up will be going out to 10 years. Unfortunately, they don't have follow-up in terms of myocardial infarction to know what happens there. Now, ischemia does have limitations. It didn't enroll the full-powered cohort for death or MI, as I mentioned, didn't have ACS. Patients with left main disease were excluded. Reduced ejection fraction, by and large, was not included. And then those that had more severe symptoms or symptoms that were refractory to medical therapy were not included because of the way that the trial was designed. There are some sub-studies from ischemia. This is an interesting one in people with low EF or heart failure. There was an even more pronounced treatment benefit, and I think that speaks to the risk of this heart failure population. We certainly know that from the STITCH trial that there's a mortality benefit to surgical revascularization among patients with depressed ejection fraction and ischemic cardiomyopathy. But we have to be circumspect because the REVIVE trial, which was published last year, didn't really show that effect with PCI. There's a lot more to be seen from REVIVE specifically. Key points that I've sort of have mentioned about this trial is that the mean age was 10 years older than it was in STITCH. And so there's a lot of non-cardiac events that start happening when you're of that age. And then further, despite the EF being less than 30, 50% of the population had two vessel disease. And I'm not quite certain how you get that. And so we're waiting the angiographic analysis, which will hopefully be published or presented in the fall to study this a little bit further. That having been said, to summarize on the data that I've shown you thus far, the Guidelines Committee gave a 2A recommendation to revascularization to reduce cardiovascular events in stable ischemic heart disease. So that board question answer that I mentioned before, when you ask your residents, is there a benefit to to revascularization in terms of heart events in stable ischemic heart disease? The answer is not no, there's no benefit. The answer is that in those patients that have multivessel disease or severe anatomy, there actually is a benefit. And this is anathema to what is currently being taught, I think, in medical school currently. Now, this idea of focusing on the highest risk patients is what I'll leave you with. And I think the reason that I'm somewhat passionate about this is because I do think that there were people who were telling patients that they were saving their lives by treating the third obtuse marginal in somebody with marginal symptoms. And that's just not true. I actually call that, shamuloplasty. That doesn't, and you can do it, but you could probably do it safely, but that's not what the patient needs. On the other hand, if we focus on these undertreated patients or those with the highest risk anatomy and those with the most severe symptoms, those are people who could really benefit. And that's kind of what we wrote in this paper that's from 2016. We came up with this term of CHIP, which is complex higher risk and indicated patients. And a lot of people have questioned this and indicated part. The reason we included that was not to say that every patient with complex disease is indicated. In fact, not at all. What we were saying was that if there was an indication, then those are people who ought to be treated. And the indication would have to be severe symptoms, heart failure, something else that would drive you beyond the anatomy alone. So the idea here is actually to not just look at the anatomy, it's to look at the patient as a whole. We divided these into multiple groups. These are often folks that were being turned down for surgery. They had complex disease, their ventricles were bad, they may have had other comorbidities, and it includes a wide variety of lesion subsets. I would really emphasize that this really goes beyond just the anatomy, and you have to be really smart about looking at the patient, looking at the echo, looking at the MRI, understanding the right heart cath hemodynamics, and all of this in order to treat these patients effectively because they have a higher rate of adverse events. Back to my soapbox about lipid therapy, these were data from our own cath lab, patients coming in with high risk anatomy. How frequently were their lifestyle goals and lipids and that at baseline? Actually not really well. The LDL was under 70, only 43% of the time. And that's what instituted us to change our pre-cath labs and to try to institute a program where we were treating them medically as well. So it's not just about what we do in the cath lab. As far as what we do in the cath lab, there's a lot of stuff you need to know. And I'm not going to go through this in detail other than to show you that you need to know a lot of things to be able to treat these patients effectively. And you also have to understand that the risk in these patients is higher. So you're incurring a greater risk despite knowing, with all these technical issues as well. And this kind of gets to the conclusion of the talk. And I would say that in a way, this is going to improve equity of care and revascularization. So the Guidelines Committee, you all know when the guidelines came out and what was going on in the US with and the world over with the pandemic, one of the first recommendations was that in patients who require revascularization, treatment decisions should be based irrespective of sex, race, or ethnicity, and really should be based on clinical indication to reduce disparities of care. And we completely understand that and are fully supportive of that in terms of where people are in terms of their socioeconomic status, demographics, et cetera. But what's interesting is patients can't really control what hospital and what physicians they see either as a result of that. And so there are differences in terms of how people treat people based upon their own training and experience. This is a sobering statistic in terms of PCI, where nearly half of operators perform less than one PCI a week. It's going to be impossible for operators, for the most part like this, to be able to treat these complex patients. So how do we get patients to operators that are going to be able to be comfortable to treat these patients safely and effectively? In addition, it's not just about PCI, it's also about surgical expertise. This is a pretty famous slide from the Syntax trial. This is a randomized trial of PCI versus surgery. And in this trial, at individual sites, each of which is represented by one of these bubbles, there are some sites that had a 40% rate of adverse events with CABG and 10% with PCI. And another site here that had a 50% rate of adverse events with PCI and 0% with surgery. If you're a patient with the exact same anatomy that's amenable to either approach, what you want is going to be dependent upon which site you go to. If you're at this site, I can assure you, you don't want to have CABG with the exact same anatomy. Whereas if you're at this one, you would. And so that's really important. And I think that's a true disparity in care that we need to be very, very circumspect about. So this go back to our patient who came to us, and this is a patient that came to our CHF service and said, "I think she needs a cath." So we ended up cathing the patient. Fortunately, she was referred to us. If this had just been taken care of at the patient's institution without referral for actually what ended up being the wrong therapy, then who knows what would have happened to this patient. So we ended up cathing the patient, and she had severe multivessel coronary disease. We did the diagnostic. The right was occluded, and there was severe disease of the circuit, the LED. We did a right heart cath and was taken off the table for a discussion with our surgical team, because I think that's the right way to do these cases. We actually got a PET that confirmed viability in all territories because there was question of a prior infarct. And ultimately, she ended up undergoing coronary revascularization with us of the LED circumflex and the right coronary artery. We did it with hemodynamic support. There's a lot of active interest in whether you need hemodynamic support or not. My sense is that the trial Protect 4 needs to enroll, but my sense is if the hemodynamics are bad, then you generally need hemodynamic support. If the hemodynamics are okay, even if the EF is low, if you're a good interventionalist, you likely can do the case without the danger of putting in a hemodynamic support device. But that we'll wait for the randomized trial data to inform further in that way. She actually got an EF improvement. Her symptoms got better as well. She was quite symptomatic at baseline, which is unlike the revived population. And I still follow her as an outpatient. One of the other things that's super important, and I'll sort of end on this, is that in the guidelines, there are ideal components of the informed consent process that are outlined. These tables can always be hard, but I will highlight a few things. And the first is to spend sufficient time to engage in shared decision-making and allowance of a second opinion. So encourage or allow people to see other people who may be more experienced than you are in terms of doing these procedures. I think that's super important. And certainly, if you're going to be the referral center, make sure you communicate with the treating physician who knows the patient far better than you do. Discuss specific risks and benefits with regards to all of these quality and these endpoints, as well as uncertainties associated with the treatment strategies, and provide information on the level of operator expertise, volume of the facility, and local results in these options. This is aspirational. I don't think much of this happens in clinical practice, but that doesn't mean that we can't emulate that in our own clinical practices going forward. So I think it's something to think about. So this is sort of a final slide that I like showing. And this is because one of our former presidents had a coronary stent placed, and it was deemed at the time to be an unnecessary procedure in the press. These are quotes from prominent figures in medicine, really American medicine at its worst, poster child for the inappropriate use of stenting. What I thought was super interesting is I'm not convinced or I'm not aware that either of these two physicians had any knowledge of the case other than what was reported in the media. And frankly, as a good clinician, you really need to see the patient before you start Monday morning quarterbacking. And we know that you see this all the time. I'm presenting at cath conference right now in cath conference. If you weren't there and you really didn't see the procedure, just give the operator a little bit of leeway to explain or at least tell you what they were thinking when it happened. But what's actually even better than asking the operator what happened is asking the patient. And so this former president was interviewed at a meeting and asked, what did you think about everybody commenting about this? And he sort of explained what happened and said he had a severe stenosis of his LED and it was treated, and he really wanted to bike a lot, and there was concern that he would be able to bike the way he wanted to, 40 miles at a time, et cetera, et cetera. And ultimately, he summarized it in a way that, whether you like him or not, only he could. He had this penchant for one-liners. And he basically said, well, it wasn't their LED. So they can say whatever they want, but if it's not their LED, let's reserve some judgment. So I hope I was able to convey to you some of the ways I like to think about this whole field as a clinician, a patient-oriented clinician, and certainly happy to take any questions at this time. So thanks so much for listening.
That was terrific, Ajay. That was a real tour de force. I'm sure there's going to be questions and comments from the group, but I'll start. I feel like there's a lot of scrutiny placed on interventional cardiologists. So, some of those comments you showed, which are from other, cardiologists, there's a lot of sort of, sniping and things like that. But from looking at a lot of the data you showed, I feel like one of the targets or zones for intervention to improve the overall quality of what we do is upstream of the cath lab. We end up getting a lot of these patients referred, the abnormal stress test, minimal symptoms, maybe some, historical practices which haven't changed. I just wondered, do you give this talk to general cardiologists? I mean, we have some general cardiology fellows here. Because I feel like a lot of the discussion and scrutiny is always on the interventionist.
Yeah, I fully agree, and for sure, I from this is kind of what I usually I gave you some options about what we could talk about, but this I like to frame this as either an internal medicine or a general medicine grand rounds or a cardiology grand rounds type of talk because you know, for me, one of the best things about being an interventional cardiologist is that I can do everything. There's no reason why I can't manage the medical therapy as well as a preventative cardiologist can. Now, I will fully admit that there are subtleties to the management that I always call upon colleagues who have expertise in that area to help with, but I can do everything. And so that's why I really like the field. And that's why I actually tell all of our trainees they really should continue their clinic. I have a clinic that I see general cardiology. I see, you know, young women with palpitations, AFib, and everything. And the reason I do that is because I think it makes me better in the lab because I think my decisions are more patient oriented and less anatomy oriented. So I think that the upstream management is super important. It is a major issue that we see currently. As you know, Yusuf, I've been involved in the hypertension space on renal denervation, and you know, just basic hypertension is such a public health problem that's undertreated. But again, I feel like all of those things do make me a better interventionalist because I feel that I have the capacity to do it all in a sense, and not just focus on one specific area in the cath lab.
John, you had a question or comment?
Yeah, Ajay, thank you for a wonderful talk. You know, you showed a slide that I think highlights and sort of grows off what Yusuf was saying, and that is the frequency with which we bring patients to the cath lab that have no significant disease versus other countries, and given healthcare expenditures, et cetera. Not only is it a risk to patients, but it's probably not a benefit to society in general. Ironically, you know, while Europe and most countries have gone towards CTAs and have found those to decrease the incidence of patients coming to the cath lab, our experience, if anything, here is different. The more CTAs that are done, there is equivocal things. And I'm not sure if it's because we have radiologists reading who are sort of used to reading equivocal stuff when it's lung cancer and you really don't know. But I'm curious your experience with it at your institutions and how you think we change that from a practical standpoint, because it's obviously not just Yale. We see that across the United States with CTAs and the number of patients that go.
Yeah, I mean, 100% agree. And I hinted at it during the talk. There's this rash of, I get phone calls, you need to cath this patient tomorrow. And why? Because they were asymptomatic. They had a coronary CTA that showed, you know, a 50% or 60% lesion. And literally the doctor treating the patient, who may have been a primary care doctor, who then called a radiologist and want to admit the patient and get the patient cath. And so I actually have I see a lot of like second and third opinions in my office, and half of them are people who I'm convinced they don't need to have a cath as a result. So I think we just have to not overreact. Some of it is new. People are not used to seeing it. I typically call radiologists back. I had a case just a couple of weeks ago where I asked them to do heart flow on the case. And by the way, heart flow or doing CT-FFR is a good way of whether you believe the rest of their data or not. What's pretty clear is that you can reduce unnecessary caths by doing the CT-FFR because you improve the negative predictive value of the study in a sense. And so what I called the radiologist up and I said, can you get heart flow on this? Because they didn't want to do it. And he said, well, why? I mean, the patient has a lesion. I said, well, and I explained the data to the patient, to him. I said, listen, I can cath this patient, but I'm going to likely leave it alone because it doesn't look all that obstructive. And we also need to understand how to read a little bit of CT too. You, John, on the structural space, you read your own CTs. I think that's great. I've had numerous occurrences where patients have told me that they asked their interventionalist to look at the CT and the interventionalist says, I don't know how to read them, or I don't look at them, I trust the radiologist. That's unacceptable. You got to know how to look at the primary data yourself. And so I think that when I spoke to the radiologist and explained it to him, they ordered it. Of course, the CT-FFR was, 0.95. And then I followed up with the radiologist and by the way, this is not a Columbia radiologist, this is an outside radiologist. And hopefully through that educational experience, we could prevent this cycle of things occurring. But you have to go the extra step. And of course, I'm lucky that I practice in an environment that's not RVU driven and I'm not on a treadmill seeing and churning out patients I think we have to do more of that in a sense to prevent this cycle of just coming to the cath lab and then having, for no reason.
Yeah.
Ajay, this is Samit Shah. Thanks so much for that great talk. I just wanted to follow up on what John said about these patients coming in with minimal or no disease. I think these patients may have minimal disease on a CTA or an angiogram, but many of them have symptoms. And so we have this, physiology program, and we incorporate physiology testing into this workup of ischemic heart disease. So what do you see for the role of assessing the microvasculature for patients who have epicardial disease as a comorbid process? And, my sense is that it makes your treatment effect better if you can tease those two things out. But I just wanted to hear your thoughts.
Yeah, I fully agree. I think it's important. I do think that the prevalence of true microvascular disease has been overblown personally in the if you it's a hot topic, and many people look at Manesh Patel's paper in the New England Journal and they say that 40% of patients with obstructive disease, with antecedent testing have non-obstructive disease on in the cath lab. Most people don't know, and Manesh will be the first to tell you, that in that New England Journal study, which was based on the NCDR registry, you could get in as a positive non-invasive test with an abnormal resting EKG. It's not true ischemia on a good stress test. And so I would say that in a urban environment with a lot of community-based stress testing that goes on, far more commonly do I see a bogus stress test or a misread stress test as the etiology of the patient's ischemia than true microvascular dysfunction. The second point that I'll make about microvascular dysfunction is that many of these types of patients have been strung along, and simply giving a diagnosis to a patient and saying, I understand what we're treating and this is the treatment for it, actually is a lot of the treatment benefit. In fact, that's what was seen in the Cormica study, was it was the diagnosis rather than the treatment per se that's necessarily changing the outcome. So I do, and it's not to poo-poo the field. I think we definitely have to look into it, but we have to be a little bit you don't have to do it in everybody that's referred to the lab with an abnormal stress test, because sometimes just by talking to the patient, that this was just nonsense from the beginning with an overread stress test. The final point I'll make is I personally think that, or I have hope that this can be done either with angiography or via CT and AI, rather than having to put a guide and a wire and do microvascular testing in that way. We certainly do it. And, I had a great case of acetylcholine-induced spasm that really conclusively nailed the diagnosis in a woman who was really struggling last week. But I do think for many patients, hopefully that can be done without having to instrument.
Steve, you had a...
Yeah, Ajay, thank you very much for your talk. One quick question. You started your talk referencing appropriate use criteria, which are now 20 years in practice. Do you think that in the context of everything you said about stable ischemic heart disease, that A, appropriate use criteria are still relevant, and then B, deserve some updating or refinement based on what you've outlined here today?
Yeah, I mean, I think everything can always be updated. I think that in general, it's good to get a sense of of a rubric of what makes sense and what doesn't. But I think what's happened in the last 20 years is that the practice patterns have converged that way. You were about to start this fellows course, and I think maybe it's Pollyanna for me to say this, but I really think that people are trained better now. I don't see our fellows, pushing to revascularize lesions in asymptomatic patients. In fact, and I think this is a good thing, is that I think that there's actually a little bit of expressed discomfort when somebody sort of tries to proceed in that way, despite the fact that PCI volumes are down and our fellows want to get their PCI numbers. I do see that that's at least expressed a little bit more. Why are we doing this again? That kind of thing. So I think that's good. I don't know if it's all that relevant. The funny thing is, if you look at the rates of inappropriate, and we said this from the beginning, Jeff Moses and I used to have this conversation all the time, is that in the very beginning, the rate of inappropriate PCI is actually super low. And if you look at orthopedics or other spaces where this has been studied, you're always going to have a rate of inappropriately rated cases because, not everything fits into the algorithm. And so it never was really that big a problem. I think it's just because PCI is a big business. And as Yusuf said, people like to sort of, point at interventional cardiologists, for financial reasons, et cetera, that this received so much attention. But I think that in general, though, I can't poo-poo it too much, because I do think it did a good thing with our field, that and some of the trials that came out.
We have one question in the chat from Sam Hart, saying, as a field specialty, do you think we're ready for a paradigm shift? Currently, non-invasive cardiologists order a cath. Should they instead be referred for an invasive consultation?
I mean, that's the model in which I practice. You know, when people refer me cases, I talk about the case up front. Sometimes I'll offer them CT if I think that that's relevant. I will, you know, when I get the diagnostic pictures, I will discuss it with the referring, and we'll come up with a plan together. It's not this black box of I'm sending to the cath lab and God knows what happens when they show up there. So I think that's important. I also, though, think that we can't, if I'm meeting the patient for the first time, I have to be really respectful of the long relationship that that non-invasive person has with their patient, and understanding that they may say one thing to me, but that person knows the patient better over time. And so that's also important in this conversation too. But yeah, I certainly see it us in a consultative role and an educational role as well, which is, I think, why it comes back to thinking. I think the cath lab always excited me because you could use your hands, but you also could really think about what was best for the patient in that environment.
If you have time just for one more question, I know that you need to start the fellows course. Do you think that, you know, I feel like over the last 5 years or so, maybe with ischemia coming out, that there's this theory that keeps getting pushed that detection and relief of ischemia is actually not important, and what's important is the plaque burden over. Do you think that's a valid, you know, concept, or do you think it's a slight overreaction?
No, I don't think it's one or the other. I think anatomy usually trumps function when you look at the studies. Even Courage, that was the case, and others as well. But that might just be because the functional testing was not as accurate. I think that plaque burden is clearly going to be associated, and has been shown in multiple studies to be associated with outcomes. But there's also this intriguing association with plaque burden and ischemia. So there's studies that look at plaque composition and characteristics, and they tie that to ischemic abnormalities that are seen. So I actually think that we have to be integrative and combine everything together. And that Annals paper, which is somewhat interesting, doesn't have functional assessment, but it does have severity and extent. So kind of a 2D look at the coronaries in a sense, and they're complementary and additive. And I'm sure that the ischemic burden functions the same way, especially if you do it with a good test like a PET.
All right, I think we'll wrap up there. Ajay, thank you very much. Thanks for joining.
Thanks so much. Thanks. Hope that was helpful, and look forward to seeing you all in person.
Terrific. Thank you.